So it just needs a second just to boot up. And once it's booted up, I will let the attendees in. So it just needs a second just to boot up. And once it's booted up, I will let the attendees in. All right. Letting everyone in. All righty, good evening, everyone, and welcome to DMPs of Color Mentoring Moments series. This is the first of many lectures that we'll have, and tonight we'll be featuring a dynamic panel group in which we'll be discussing, yes, you can call me doctor, how to navigate the doctor politics in real life. So we're going to go ahead and get started with our presentation. So my name is Dr. Danielle McCamey. I am the founder, president, and CEO of DMPs of Color. And before we get into our program, I just want to just share a little bit about us, our mission, vision, and objectives. So as DMPs of Color, our mission is to serve DMPs of Color through networking, mentorship, and advocacy to increase diversity in doctoral studies, clinical practice, and leadership. Our vision is to inspire, empower, and transform the landscape of nursing by increasing diversity in the Doctor of Nursing practice degree. And our objectives are to create opportunities for engagement in academia, research, and clinical practice, to advocate for educational support for DMPs of color, and to serve as mentors and guide nurses of color to pursue their Doctor in Nursing practice studies. I'd like to introduce our moderator for tonight, Ms. Cianti Stewart-Reed. She is a longtime friend, and I'm excited that she has volunteered her time and expertise to help us move through this engaging discussion. Without further ado, Cianti.
Thank you, Dr. McCamey, and thank you to DMPs of Color for having me tonight. I just wanted to speak a little bit about sort of the ground rules for our conversation. I'm sure it will be robust and engaging. Just make sure you mute your microphone when you're not speaking, unmute when you're ready to speak. For right now, turn off your video just to decrease distractions, but we'll ask you to turn it on later during the forum. If you have questions, please enter them in the chat box. That's how we will take them later in the forum. We will have time for your questions, so hold on to them, put them in the chat box. We'll be sure to get to you. Be engaged. Let's have a wonderful conversation. You've got an engaging panel that I think you're going to learn a lot from. So let's get started. So I'm really pleased to be able to introduce a dynamic panel for you all tonight, starting with Dr. Derrick Glymph. Dr. Glymph is the Enrollment and Global Initiatives Coordinator and Clinical Associate Professor in the Nicole Wertheimer College of Nursing and Health Sciences Graduate Nursing Department at Florida International University. Dr. Glymph started his over 20-year career in nursing as a licensed practical nurse and continued to advance practice certified registered nurse anesthetist. Dr. Glymph received his associate and Bachelor of Science degrees in nursing from Norfolk State University and his Master of Science and Doctor of Nurse Anesthesia Practice from Virginia Commonwealth University. He is currently pursuing his PhD in nursing science, focusing on substance abuse and opioid use disorder patient outcomes at the University of South Florida. Dr. Glymph is a governor-appointed member of the Florida Board of Nursing since 2015. He also holds a staff appointment with Memorial Regional Medical Center. He has been involved in clinical practice, teaches in the classroom, simulation center in NWCNHS for 9 years. In addition, Dr. Glymph holds the rank of colonel in the United States Army Reserves and serves as chief anesthetist of the OMI 7456 Medical Backfill Battalion, USAR. Dr. Glymph experiences include Operation Enduring Freedom in Afghanistan, along with multiple leadership positions in the military. Next, we have Dr. Nikita Patel. Dr. Nikita Patel is currently a family nurse practitioner at MedStar Health. She received her Doctor of Nursing Practice from the University of North Florida in 2018. She's an active member of the American Academy of Nurse Practitioners, the District of Columbia Nurse Practitioners Society, and the Society for Vascular Surgery Nursing. She has many years of nursing experience in progressive medicine and trauma surgery. She enjoys teaching and mentoring new nurse practitioners and was previously an adjunct professor for traditional and accelerated BSN students. During her career, she has advocated for the independent nurse practitioner clinic in the vascular surgery department at MedStar Georgetown. Dr. Patel is currently working on a grant-funded project to bring recognition to pelvic congestion syndrome awarded by Women's Vascular Summit. Nikki has a passion for empowering and mentoring new graduate nurse practitioners and registered nurses that want to transition their skills to become advanced practice providers. She's a strong advocate for nurse practitioners having full practice authority to reflect the extent of APRN's education and training. In her free time, she enjoys traveling, pre-COVID like all of us, spending time with her family, trying new recipes, and exploring the city with her dog. Our next panelist is Dr. Tamira Brodnix. She serves as the president of the Central Virginia chapter of the National Black Nurses Association. The Central Virginia chapter extends around a 100-mile radius of the city of Richmond. She's a board certified nurse executive advanced, and she has expertise in leadership and new program development and implementation. Clinically, she has served as a nurse manager, nurse clinician, VCU School of Nursing adjunct clinical instructor, program manager, department director, nursing director, and consultant. She has worked at health systems in the federal and private sectors and has served on a number of boards and committees. She currently works as an analyst in the Clinical Command Center at the Central Virginia VA Health Care System and sits on the Virginia Nurses Association, Virginia Legislative Nursing Alliance, and Diversity, Equity, and Inclusion Councils. Dr. Joycelyn Thomas holds a Doctor of Nursing Practice degree from the University of Washington. Currently, she works as a family nurse practitioner at a family practice clinic for Catholic Health Initiatives, where she's also the medical director. She is a nurse practitioner specializing in the care of persons of all ages, and her interests include HIV care and prevention to HIV/AIDS infected individuals, specifically individuals of African descent, pregnant women and children exposed and infected with HIV/AIDS, global health and improving patient-provider communications with African Americans. Again, welcome to our esteemed panel. And so we will jump right into our discussion for this evening with the first question. Again, thanks panelists so much. If you would just start off for us with briefly sharing why you decided to pursue your doctorate in nursing practice. Why don't we start in the way that we introduced, and we'll just move on from there. So we'll start with Dr. Glymph.
Good evening. How's everyone doing? Can everyone hear me? It's interesting how when I finished my master's in 2004, there was not a terminal degree for nurse anesthetists. So the school that I went to, Virginia Commonwealth University, they were the first school to develop the Doctor of Nursing Anesthesia practice. So it's interesting, I graduated in 2004, started practicing in 2005. And I always tell this story, 8 months after graduating, I got a call. I was a captain at the time. And they said, Captain Glymph, you're going to Iraq. And they said, Captain Glymph, you there? You're there? And I'm like, you're just telling me I'm going to Iraq. I ended up going to Afghanistan, and it really changed my whole paradigm. going there was a life-changing experience in terms of focusing. I realized, I said, you know what, I need to go back and go to school. Virginia Commonwealth started their doctor of nursing anesthesia practice in 2008, and I was in the inaugural class. I think, so the genesis occurred when the program director was saying, he said, by the time you guys graduate in a couple of years, we're going to have this particular program. And I was very intrigued. Then of course, Afghanistan happened. And so from there, it spearheaded me to go ahead and pursue my doctorate.
What about you, Dr. Patel? What made you decide to pursue a doctorate?
So I knew I wanted to become an advanced practice nurse. And when I was researching the differences between a master's prepared a nurse practitioner versus a doctorally prepared nurse practitioner, the main reason why I wanted to transition from an RN to an NP is that I wanted to be able to, better dictate the care for patients rather than, taking orders that were given and implementing. But I wanted to understand more why they are being done. What is the evidence? What is the science behind why it is what we're doing? And, better understand. And I felt like doctoral programs taught nurses to take the evidence and implement it and really understand, is this good for patients? Is this not good for patients? So it was really that, in addition to increasing my skills, I wanted to understand why we were doing the changes we were doing and, really understand, why we have protocols the way we do.
Thank you. Dr. Broadnax?
Hello. So I think my story sort of parallels Dr. Glymph because I started my master's back in 2005 at VCU as well. And I was in that first class to get their master's in nursing administration and leadership. So I finished up my master's back in 2007, and that allowed me to transition from the ICU into more administrative type roles. So I started doing a lot of different types of leadership roles. I was a nurse manager, a nurse clinician. I taught as an adjunct down at VCU. I became a program manager. I became a department director. And along the way, I really enjoyed new, innovative things and introducing those things into practice. So I was the first facility telehealth coordinator at McGuire at the VA. So I set up that program. I was hired at VCU as their first telemedicine director and their first director of nursing in telemedicine. And I was relying on my skills as a master prepared nurse, as a nurse executive. And about a year into that program or into that position, VCU offered the DNP program. And so that caught my interest. And at the time I had to decide whether I was going to, go clinical or go administrative, or if I wanted to teach versus being in a clinical setting. So with VCU starting the DNP program, that was a huge opportunity for me to do the things that I enjoyed. And instead of pursuing a PhD, I decided to look at staying in a hospital or clinical type environment while working on my doctorate. So it was an extension of what I was already doing. And it's basically an expansion of the skill set that I had when I was an administrator. And so I started that program back in 2015. And I was also in the first inaugural class to graduate from VCU with the DNP. Thanks.
Great, wonderful. And Dr. Thomas, what made you decide to pursue a doctorate in nursing practice? You were on mute, Dr. Thomas.
Was saying that it's so wonderful to hear everybody's stories and making sure you guys can hear me. And of course you couldn't because I was on mute, but I've been a nurse now for 24 years. I went to school a little bit later in my 20s, after having children. And probably about 5 years after I started nursing, I knew I wanted to go back to school. But I had small kids, and everything I looked at, I kept thinking, oh, it's not going to fit into my schedule. And so I did a lot of different things. My background is in perinatal. I did management, coordinating, program management, inpatient, outpatient, and perinatal and high risk. And then I ended up in research and doing large clinical NIH trials with HIV infected women and children. And I would say that my work in research really started to spur my interest in going back to school, because I was that much more, believe it or not, in research, exposed to the inequities in my community. And it was my passion for my being able to feel that I could impact change that spurred me to go back to school. So I started looking, and I actually was looking at RN to MD programs. And so in my searching, I said, let me look at the UW again and see what they're offering, because that is where I graduated from with my bachelor's of science, and the DNP program was there, and it was in its second year. And so I was so excited about what I read, because it fit exactly into what I was interested in: leadership, advanced clinical practice, and policy. And so I said, okay, this is it. And so that is really what spurred me to go back to school, was seeing the inequities that much more, believe it or not, in the research setting and what I was doing. So, yeah.
Wonderful. Thank you all for sharing really a diversity of experience and paths to this degree, I think is what you all demonstrate. Please remember, if you have questions for our panelists, to put them in the chat. We'll get to them in the open forum. The next question I'll throw out to the group. The DNP degree, as several of you have stated, was first introduced in nursing in the early 2000s. And it's fairly new to the nursing profession in comparison to the PhD. Because of this, some might not be aware of the differentiation between the two degrees. What do you say, or what's your elevator pitch when asked about the DNP degree and how it differs from a PhD in nursing?
This is Dr. Glymph. It's interesting working in academia and actually, like you said, pursuing my doctorate, my clinical doctorate early, and now pursuing a PhD. So I can kind of speak from both standpoints, but the clinical doctorate really gives you, it is just that. It's a clinical doctorate that you're dealing with the practice of your field, and currently the practice or the current issues that are facing your particular track or field, where the PhD is new research. So and you can evidence-based practice I think is the earmark piece of the clinical doctorate, in terms of evidence-based practice, innovative things that we can improve the practice of whatever field we're in, with the literature and the research backing it up.
Like Dr. Glymph said, I think the best way to describe it in like one sentence to people that ask me, what is the DNP? We take the bench research that nurses that are PhD prepared show us, and we implement it into practice to have better outcomes for patients. So it's taking, the data that is presented to us and how can we implement it for patient care. Is the quickest way I can describe it to people.
That's great.
And along with that, I'd like to add that it's not a position, it's where you are in your practice. And attaining a DNP shows that you have acquired a skill set that's more advanced than a master's prepared nurse, and you're able to take on additional responsibilities. I was going to talk about implementing changes, and that's already been covered, but something to think about, it's not a position, it's where you are in your practice. And by you having your DNP, when you sit at the table with other folks who have their doctorates, you fit right in.
Dr. Thomas, you need to unmute.
The hallmark of a DNP is to, of course, implement evidence-based practice, advocacy and policy, advance clinical practice, interprofessional relationships, working with that, and also to advance scholarship. So I think that Dr. Broadnax said it well. It kind of depends on where you are and also what your own skill set and how far do you want to take it. Because at my school that I have graduated from, there are DNPs that are doing novel research and working alongside with other PhD nurses, epidemiologists, global health researchers, medical doctors. I could go on and on. And I think it really just depends on like how deep do you want to go? But in my own endeavors, trying to understand and see what is the difference between the two and how would you want to use that. For me, in my experience, I felt like it's much more heavy in the epidemiology and the science. So that if that is something that for example, there are some programs that do DNP PhD, because you have that advanced clinical practice coupled with that deeper understanding of how to move and research forward, whether it's qualitative or quantitative bench work, whatever. So I think it's it can be very individualized based on where you are.
That's great. The next question I think flows perfectly from this. The DNP degree focuses on education in evidence-based practice, quality improvement, and systems leadership, among other key areas. How has your DNP influenced your clinical practice and or your career?
What's interesting, I'll start off. As a result of getting my doctorate, I ended up going into academia. And I end up moving from Virginia to Florida, so completely making a real life-changing move to there, and it's probably been one of the best things that ever happened for me in terms of opportunities. Never in my wildest dream would I think I would be on the board of nursing in any state, but also the opportunity that it's given me, like the panelists have said, in terms of working with students with evidence-based practice, quality improvement. It's definitely increased my understanding of those type of things and helping translate students to understanding evidence-based practice and having them put all that body of work in terms of, because like Dr. Brodnix has said, it's about where you're at. And many of our DNPs are already, they're already RNs, so they've been practicing for a number of years. And I remember when I used to interview people, I say, when you practice, what's broke and how would you go about fixing it? And that simple question is to start thinking about what kind of quality improvement processes can you come up with to improve your practice. And that's, to me, that's going at a higher level in terms of not just going to work every day, but you're starting to look at things and say, how can we make our practice better?
Anyone else want to chime in on how having the DNP has influenced your career or your clinical practice?
Dr. Glymph, again, I agree with you. While I don't need a DNP to do what I do in vascular surgery, I think I'm actually the only MP in our program that has a DNP. And from that, you know, it was like, why? There's so many things that we can improve. Why is no one working on this? And I think that no one just really thought about the initiatives or how to go about doing that. And I think a doctorally prepared nurse is taught those leadership skills and to understand organizational structure and how to kind of fix a problem from the root and to help the whole organization. And so, you know, we were having a hard time getting patients in timely manners, and the District of Columbia is an independent practice state. And so one day I just asked, why are MPs not working independently? Why are we not doing this? And it was such a novel idea. And so it really has made such a significant difference. We can see patients independently now. You know, people can be seen quicker and sooner. And it was just, I think you were just taught to problem solve a little differently, and then how to approach it with leadership, having to work with administrators and directors and managers and how to come about with those solutions.
And I also think it's important that we bring that nursing perspective to the table. So in my particular case, it was an expansion of the things that I was already doing. My DNP focused on quality and safety. And as I became a nursing director, I found myself on more boards and serving as a consultant to other health systems. And having the DNP allowed me to refine my skill set, because a lot of times when you are thinking about innovation and you're thinking about making changes in practice, it's good to have that perspective, because I believe we aren't always represented. I was working with telehealth for almost a decade. I was a co-chair of the National ANA panel on telehealth, and we just revised those principles. And oftentimes those people who make those decisions aren't nurses, they're clinicians. And so being at the table with these people, and you understand the work and you understand how these processes go, I think that brings value to the whole group setting, and it helps. So as we make changes in practice, as we look at innovation, I think DNPs are important to make sure that the transitions are smooth and that the nursing staff is prepared to embrace the newer challenges that we have with technology and all the other things that happen in practice. So I believe that the DNP actually is the right type of, I don't want to say position, but it's the right type of training to have when you're in a clinical setting, because, you know, the PhDs are doing the evidence-based practice, they're researching, but to actually translate that research into practice, you really need nurses who understand how these different clinical settings work and how these changes, you know, affect the workload and your productivity and the quality.
That really, I think, is a great segue to our next question, which is nursing has the ultimate goal of moving in a direction similar to other health professions, MDs, dentists, doctors of dentistry, requiring or offering practice doctorates. Do you believe nursing should require a doctorate as an entry-level education in nursing?
Can I clarify that question? Do you mean as a registered nurse or as an advanced practice provider?
I don't have the expertise here, so you tell me what you think it means.
Either way.
Either, okay. I think to be for advanced practice clinicians, I think it should be mandatory, really. And I hope that we moved. I know that the goal is to move towards that. It was supposed to be 2015 and probably not happening in 2020. So I don't know when the next benchmark is, but I think that the respect, and I can only speak to the MPs. I'm not in leadership, and I'm not a nurse anesthetist, but Dr. Glymph might be able to agree with me on some of this, and Dr. Thomas as well. But what we do and the care that we provide, I think, is undervalued and not really recognized properly, because we don't have the title as physician or MD. And really, when you look at the evidence, our outcomes are great when we have for patient care. And so I think to continue to support that narrative, I think we should have training that reflects that. And I think a doctorally prepared nurse does have that. For RNs, I think where they're going at now is having a bachelor's is, I think, sufficient. I don't know that anything more for an RN is needed at this point. For bedside nursing, rather, to go into leadership, certainly, I think those are skills that you should have, especially when you want to sit on committees and boards that really want to make and improve hospital organizational structures and things like that.
So I'm going to comment on this one as well. I'm going to ditto what Dr. Patel said, but I would like to add that, expound a little bit, that I absolutely believe the doctorate is, I'm not going to speak to RN, I'm going to speak to advanced clinical practice. I do believe that as a nurse practitioner, advanced clinical nurse practitioner, that definitely the DNP should be required. And the reason I believe that is because of your education is to prepare you for advanced scholarship, as I said before, evidence-based practice and policy. Those are like some of the mainstays. And if you are going to be effective and not just a rote bean counter in your clinical area, if you want to make change, if you want to impact, having that education helps you to navigate that. I'm the medical director. But I was sitting on 2-3 committees, and I'm on the Regional Leadership Council, and my skills have been imperative in that area that I learned in my graduate education. Without those skills, I wouldn't be able to have the conversation about reimbursements with Medicaid and Medicare, and sitting on compensation committee and talking about why it is that nurse practitioners are valued and we should be getting paid commiserately. So I just think that it's really important. Now, to some people, for them to have an advanced practice degree, it might not matter to them, but when they get in that setting and someone's starting to mess with your schedule or take away your salary because they want to cut costs, you better believe that education that you receive in the doctorate is going to be critical. And I have found it very critical for me in my experiences.
I have an interesting take on that. It's a unique question that you say that being in academia, being a clinician, and in terms of clinical aspects, I don't think advanced practice, if you're just going to remain a clinician, I don't think it's essential that an advanced practice person get their doctorate, because even though the nurse anesthetist is mandated that you are required to get your doctorate, the clinical part is the same, and many providers or many people that hire them, they really don't see a tremendous difference in the clinical aspect, because the clinical aspect is the same. To that end, you're right. The doctoral classes that you end up taking in terms of patient safety, in terms of healthcare finance, allows you to understand that bigger picture, the macro finances of the situation, in terms of everything is money related, and understanding how providers get paid, understanding what is the components in revenue, the whole process of Medicare or Medicaid or various insurances. I don't think you get a good understanding until you pursue your doctorate. But so from that aspect, I think nurses, I think we've got it wrong for so long in terms of we had the ADNs and the RNs and and so it's very confusing to the public. So I think if we have one standard protocol or process that we're, if that's the case, we all say, we are, the doctoral is the benchmark. But like to the questions, many of our organizations, they keep waffling back and forth on when it's going to be instituted.
Well, I want to thank you all for your answers. I want to turn to the hot topic question for tonight. The title of this this series for tonight, it's no secret there's a heated debate around the use of the title doctor, especially amongst your medical colleagues. So why do you think that's the case? Do you expect your colleagues to call you doctor? Or yes, no, why not? And the last question is sort of, have you had any experience where you've interacted with colleagues that did not support nurses with terminal degrees? So this is the big topic of the day, the controversy around the use of the term doctor. So anyone, feel free to jump in. I know everybody's got something to say. Don't make me calling you. Go ahead, Dr. Patel.
Okay, since someone else is going. I personally don't expect colleagues to call me doctor. I don't mean to upset anyone when I say that. I understand I worked very hard for the degree that I have. I think we live in this, we have a very antiquated health system in regards to who gets called doctor. I think instead of focusing on if I can be called doctor or not, I think there needs to be an emphasis on my physician partners as well. Explain to patients who they are and who their partners are. I make a point to say your surgeon is an XYZ, and I'm your nurse practitioner XYZ. I don't know that I necessarily need to tell a patient that I'm doctorally prepared. And on that note, I don't know that I need my physician colleagues to also call me doctor. It's appreciated if they recognize that I have a skill set that maybe my doctorate has prepared me with. But if I've never had an argument or felt disrespected because I was not called doctor. I also think I'm lucky that I work with colleagues where we go on a first name basis. I've never been corrected to say, please refer to me as doctor. So personally, I don't think I need to be called doctor. I do understand that it is very taboo. I think it's that the general public, there's confusion about using that term for nurse practitioners or for other medical specialties. And I think we really should focus on explaining that to patients, like your medical provider is a nurse practitioner, or your medical provider is a surgeon, or your medical provider is a physician. That's just my opinion.
Thank you. Anyone else have ever had an experience where you interacted with someone who was not supportive?
For me, in academia, it's you're constantly called a doctor, but in to Dr. Patel's point, can you hear me? I went blank for a second. We went blank. Can you hear me?
We can hear you.
Okay, it clicked off and clicked on. To Dr. Patel's point, in the clinical environment, I really, call me Derrick. I mean, I'm not. It's not that big a deal because we operate on such a level that regardless of them calling me doctor, and especially in anesthesia, I'm operating at that level, making those decisions. So whether they call me Dr. Glymph or Derrick, we're still operating on that life and death situation. I give you a classic example. I was in a GI situation the other day, and I had been out of clinical for 6 months. Imagine anesthesia. So I was just really feeling anxious, and I had a situation where the GI doctor was trying to do a case. And I had to tell him no. I said, we need to intubate this patient. And, and he respected that decision, and we did it. So that operating at that level, whether you're, whether they call me doctor or not, I'm making those decisions. And I guess I get that from the military, because I had the same kind of situations in the military where I've had to tell people, look, we're not doing this case. This is not safe. And they respected that. So I think it's about your what you bring to the table and your confidence and your body of knowledge that you present. I think that any provider, or whether a physician or whatever axillary people, they respect that.
Great. Yeah, I cut you off before. I'm sorry.
Yeah, so I just wanted to add, my perspective is a little different. So in my first career, I was an Army officer. I graduated from West Point over 30 years ago in the 80s. And when you come out as an officer, they call you sir or ma'am. It's not optional. You earned, that title. So even as a brand new second lieutenant, fresh out of college, I had people twice my age calling me ma'am. And I had no issue with that, because that was the role that I was expected to fulfill. I think our patients are sophisticated enough where they can tell the difference between a doctor, a pharmacist, a PT person, a psychologist, and a nurse. So they don't have, or a veterinarian or a dentist. So patients don't have a problem calling, a pharmacist a doctor, a dentist a doctor, a vet a doctor. And when you are a nurse and you've earned that degree, you're entitled to that same address that they would use with a physical therapist who also happens to have their doctorate. In my practice setting now, I work at the VA. It's not quite the military, but we don't go around calling people by their first names. We always put a title when we address someone. It's Mr. So-and-so, it's Miss So-and-so. In my case, it's Dr. Broadnax. The psychologists are referred to as doctors, the psychiatrists, the pharmacists. So if you have a title, we're encouraged to use it. And, this whole idea that you don't have to use it, just, my perspective is a little bit different, because once you've earned that title, you've earned the right to be called doctor, just like everyone else who has a doctorate in a different area.
Thank you guys for your comments. As long as I'm not called gal, I'm fine, but it's a joke. But anyway, well, really, the bottom line for me is it doesn't matter, as long as no one is addressing me in a derogatory way, if I'm called doctor or not. However, in my environment, again, I work in family practice. I'm in a medical group of over 1,000 physicians. We're one of the largest medical groups here in our area. So being on all the committees and that I'm on, and having to interface with a lot of people. So I would say that I haven't had to defend openly to anyone me being my title. No one has ever said, none of my colleagues ever said, I am not calling you doctor. In fact, most of my colleagues refer to me as Dr. Thomas. So when I'm in meetings, when I'm at the table, for anything, my colleagues are saying, and Dr. Thomas, what do you have to say? Or, and so I appreciate that, but I've never corrected anyone to say I am Dr. Joycelyn Thomas. Thank you. Now it's interesting with the patients, because I did change my title in all of my signage. And when I first started, they had AR&P, and I changed everything to DNP. And I did that so that I could educate people what the DNP was. And every day, a couple times a week, I still get a patient asking me, what does a DNP stand for? And I educate them. And so, and they appreciate that. But most of my patients, a lot of my patients call me Dr. Thomas or Dr. Joycelyn, especially the kids. Their parents have taught them that. And so for me, I am okay, because the bottom line is I'm there to give the best care I can possibly give, whether or not somebody calls me Dr. Thomas or Joycelyn. So I would say that for me, it's been positive with that title. Now, I have even had patients go to the front desk and say, why don't you have her name up there as Dr. Thomas? And so I've had the front desk come back and say, are you a doctor? So, you know, it's been good to be able to educate people around it, but I don't have a preference.
Well, thank you. Thank you all for answering those questions. I think we're going to hear from some folks who are the participants too. We want to open up this forum. Again, if you have questions, please put them in the chat. It's time to turn your cameras on so we can see your lovely faces, and whatever's happening in your background is what is happening in your background. It doesn't matter. Dr. McCamey is going to go through the, is going to select our questions. So we'll
How
sort of
beautiful, yay.
Right now, if anyone has any comments on the current question on the floor in terms of the quote unquote controversy of nurses embracing the term doctor, any experiences of your own that you would like to share on the question was posed to the panelists? Don't forget to unmute yourself. Anyone's free to chime in. All right, well, I guess I can share my experience. So my name is Danielle McCamey, and I'm the president and founder of DNPs of Color, but I also work as a chief nurse practitioner in pre-anesthesia and also a senior nurse practitioner in critical care. And when I was going to school to get my doctorate, I guess I work around a tough crowd. And so there was a camp that was super in support and respected me pursuing my terminal degree. And then there was a camp that wasn't in support. But with our clinical practice, the expectation was always to do presentations or mentor upcoming advanced practice providers. So whenever I would do any presentation, such as journal club, or if we had clinical conversations, I will always take the opportunity on my last slide of my presentation, whatever I was doing, to say, hey, I'm in school getting my doctorate in nursing practice, and this is what a DNP is. And so after doing that consistently for a year, by the time I graduated, it got everyone on board, and like they threw, like all the physicians threw like a surprise party for me and was like, congratulations, Dr. McCamey. So I agree with Dr. Thomas in saying education is key, and also encouraging people to put DNP on your badge. If you have a plaque with an office, put it there, put it in your signature lines, because it does matter. And then, and as we mentioned earlier in the discussion, since the DNP is a fairly new degree, I think it's important for us to have that visibility and be confident that you've done the work to earn this degree. And then just kind of have an elevator pitch or whatever in your head. So when people do come and ask you, what is this DNP thing? You're prepared. And one last thing, I remember the first time I had a patient, like fresh from graduation of getting my doctorate, I was like feeling myself a little bit. And the patient actually recognized, like on my badge, he's like, oh my gosh, you're a doctor. And I was like, what do you mean? He's like, you have your DNP. I have a doctor, nurse practitioner. And I was like, oh my gosh. So that really made my day. And I was really excited that the patient actually was paying attention. So yeah, that's my experience.
I just want to add one little anecdote because I feel like it's so relevant to what you just said. I again, family practice, but one of my little kids' mother came in, and this was right at the beginning of when George Floyd passed away and was murdered. And so there was a lot of tension and things going on in the air. And it was a tough day. And she said, one of my patients came in who happened to be white, and she says, was asking me how I was doing and brought me a gift and those kinds of things. And she said, I just have to tell you something. And she said, my daughter, she said her name, we were watching television and there was a African-American doctor that came onto the screen it was some sort of a health commercial. And she's 3 and she looked up at the screen and she said, "Is that my Dr. Joycelyn?" And, she said, this is where it begins. And we just had that unsort of spoken, you do have to, it's instilling from the beginning. And I feel that way with the degree that we have. And I really appreciate this forum.
Dr. Thomas and Dr. McCamey, I think what you said is really important, is that you have to advocate for the degree. I think colleagues that are physicians don't know that. I mean, just the other day I had to explain to the surgeon I work with that, a nurse practitioner as a certificate is what I'm allowed to do, but my degree is a doctorate. And they don't even really quite understand that. And so I think you have to sometimes it's just a conversation of like, I hung my degree in my office and people see it and they ask me about it. And I take that opportunity to say what it is and why I did it. But more so it's on my card and patients ask me, what does this mean? It's on my email signature. And so people know, or hopefully if they don't know, they might look it up and they might better understand. And it's even to the point where my assistants will say, "Oh, our nurse practitioner, she has her doctorate. She can see you if you'd like to be seen sooner," and things like that. And I think that's really important because you don't walk around saying, "I'm Dr. Nikita Patel. I'm a doctorally prepared nurse practitioner. How can I help you today?" So you just go and you say, "Hi, I'm Nikki. I'm your nurse," or however you introduce yourself. I say, "I'm Nikki. I'm your nurse practitioner," but people don't know, and so you just have to, educate. And I have a sister who's a physician who is very pro NP and tells everybody, my sister has a doctorate and this is what she does and this is why she did it. And so I hope that, everyone tells someone so that it can spread and they can better understand why we do what we do and why we have the degree we have.
I'm just curious, do your physician colleagues introduce themselves by their first name?
No, they say Dr. Misaki. They say, "I'm your surgeon, Dr. Misaki Kiguchi." Oh, sorry.
Right. No, the reason I'm asking is because you're setting the expectation for the patient. And you can say, "I'm Dr. Broadnax, I'm your nurse today," or "I'm your nurse practitioner today." And there's no confusion about what your role is. But I do notice that when physicians introduce themselves, they don't go in and just say, "Hey, just call me, by my first name."
You're right. No, you're absolutely correct, Dr. Broadnax. I probably will start doing that. I'm Dr. Patel, your nurse practitioner, because why not? You're right. That is my degree and my title, and it's not inappropriate to say. And maybe I'll ruffle feathers then, I don't know. So update on this later.
I was mulling this over earlier today and I thought I would consider whether or not I'd bring it up tonight. As people of color, I do wonder if that influences in any way, you think, the way that you present in terms of using the term doctor. I think, societally, the things might be interpreted differently. And I just wonder if that shows up in medical practice. We know that generally in medical practice, right, there are issues with race and issues with race equity. And so is that part of the way that, is that a hindrance to being accepted amongst your other colleagues in terms of being seen as using the term doctor?
I don't think it is. I think I kind of agree with the panelists. I think it's a part about education. And I think one of the biggest things in the what's on the platform and what's in the elephant in the room is people don't understand the DNP. They don't understand when you say I have a doctor of nursing practice, and then when I say I have a doctor of nursing anesthesia practice, like, well, what's that? So it's an educational standpoint that, like you said, you have an opportunity to educate, and people don't care how much you know until they find out that you care. And I think once you demonstrate that you care and that you have a level, a body of knowledge, because at the end of the day, we all have our own standard of practice. That I can tell you, being a board member that if you don't do that, you will be disciplined. You will be, it's not your physician counterpart that will be disciplined. You will be disciplined because you didn't act accordingly to your scope of practice. So I think once people understand that, and I think, different places in the United States where our full scope of practice, where providers are operating to the full scope of their practice, they even more are operating at that level. So I think that education piece is paramount.
I was just going to say, with other professions and other people of color, they don't have a problem, in my experience, when I've observed like a pharmacist or a doctor or a psychologist come in and introduce themselves. They always use their title, and that's how they introduce themselves.
I want to make sure, thank you very much. It's an interesting conversation. I want to make sure we get to we had a couple questions that were in the chat. I want to make sure we get to those tonight. The first one I see is for the group, do you have any strategies to implement to attain physician collaboration, specifically in psychiatry? So do you have any strategies to implement to attain physician collaboration, specifically in psychiatry? It's from Dr. Monique Frisbee.
This is Joycelyn. I probably would like to know a little bit more about that, but if you're just talking about physician collaboration in general, I would think that you would use your skills, regardless of what genre that you're in, to motivate people to be a part of something that you're interested in changing. I'm assuming that you're looking, I might want the person who asked the question to put something in the chat box. I don't know if they're practicing. I don't know if they're trying to implement something. I'm not sure, but I would say that looking for ways to motivate people to be a part of what you're doing. And so what I know that I have done to affect change, or to find ways to collaborate with physicians in my environment, whether it's my own clinic or independent practice for telemedicine. Okay. All right. Thank you, Monique, for that. So I don't think I could speak to that necessarily specifically, but I would say that you would gather people at the table that you're interested in working with, and because I've done this strategy, and then present to them why you feel the collaboration is important, and finding out from them first what they feel might be, what they might need, or what might be the facilitators and barriers to work with them in the community. Or I don't know what kind of, I know it's telemedicine, but I don't know if you're looking at people in the community or at like academic centers, but and then really trying to listen to what their fears might be, and then spend time. It's not going to be a one shot, that I've had to spend a lot of time. So several meetings, several times getting together independently, talking, listening to those people, and then being able to address, gather that information, and then be able to address whatever those barriers might be for your collaboration.
Thank you very much.
And I just wanted to add, for telemedicine, check your state requirements. Like in Virginia, you have to have practice for 5 years before you can practice independently. And then getting that collaboration is important, because you're in Virginia, at least as a nurse practitioner, you do have to collaborate with a physician in order to use telemedicine.
Great. One of the, again, if folks have questions, please drop them in the chat. We'd love to hear from you. One of the other questions here is, are we able to join DNPs of color? I live on the West Coast and would love the collaboration. I'm going to go with the answers, probably yes. I'll let Dr. McKamey chime in.
Yes, absolutely. And at the end of the chat. I'm sorry, at the end of the discussion, we'll have ways that you can get in contact with us. Everyone wave. I'm also on IG Live. Yeah, y'all like my DMPs of Color case. But yes, check us out. We're on all the major social media platforms, and then there'll be contact information at the close of this session.
Great, wonderful. Clearly a great way to continue to collaborate, meet colleagues who are like-minded. I want to go to the next question I see in the chat. It's from Dr. Margaret Apara. I address myself with my first name at the clinic. I will start addressing myself as Dr. Apara, your nurse practitioner. So we've done some education on this meeting tonight. The question is also, what are your thoughts on taking a director of nursing role as a DNP?
I think that's a natural progression. The chief nurse at my former hospital at VCU Health is a DNP. I think the PhDs you find more so in the academic setting. And I guess about a decade ago, a lot of your doctorally prepared clinical nurses were PhDs, but I'm finding more DNPs in practice. And I think it's a natural progression to actually go in and become a chief nurse once you have your DNP.
I definitely concur with Dr. Brodnix. I think that's a natural position. I was just recently the chair of the anesthesia department of our university. So definitely those are natural positions, of leadership positions that DNPs can go into. So I definitely agree with her 100%.
And I also want to chime in. I know a lot of institutions are moving toward that, the C-suite of hospitals, and I can speak to my hospital in DC, that they are encouraging executive leadership to have their doctorate in nursing practice, and they're creating space for those leaders to go back, whether it be through scholarships or allowing them to have protected time off for their studies, because they see the value of having doctorally prepared nurses that are in leadership position, and also the magnet status is always a motivator for these entities to support this advanced education.
And I just wanted to add, I did see a comment by Sherry Washington about not being a nurse practitioner and earning her DNP. That was my situation. I think the majority of the students in my class, in my cohort, were NPs, and I was administrative. And some people think it's the doctor of nurse practitioners, but it's not, it's nursing practice. I think your background in education prepares you. Obviously, you're gonna have to do your clinical hours as a DNP, but it's how you apply, what you've learned in your DNP in your practice. So you don't have to be a nurse practitioner, obviously, to be a DNP. I had an advantage because I was already a nurse exec and I had already studied administration. So a lot of the things that they were learning at the DNP level, I had learned at the master's level. So I just want to encourage you to stick with it, because the DNP is broad enough where you can incorporate people who aren't necessarily bedside clinicians or patient involved with direct patient care. There's room for researchers, there's room for administrators and educators in the DNP as well.
I have an interesting perspective being in the military, also being a colonel in the Army Reserves. And it's interesting because, being one of the first people to obtain my doctorate, I think that assisted me in getting promoted ahead of my peers. So that level of commitment and focus, I think, will help you out wherever you're at, whether it be the military or in the civilian sector. Again, in the military, they call me Colonel, so they're not going to call me by my first name. I think like Dr. Brodnix said, I think it depends on the setting in which you're at. And at the end of the day, when you're collaborating, as you work as a team, I think that's the most important thing.
So I want to again ask our participants, if you have questions, please drop them in the chat. And we have a couple, we have at least one here that I'm going to ask, and then we definitely have a closing question also. So from Kendra Thompson, lots of military people tonight. As a Navy brat and an Air Force veteran, I agree with Dr. Broadnax. Do you think that that we as nurses are prone to be on more familiar terms with patients? And that's why many DNPs don't mind if they're addressed by their own title, not addressed by their own title. Anyone have any thoughts about that? No, well, maybe.
I don't disagree with that. I think that's why I feel that I don't need to say that to patients, but for the sake of, we all have kind of this general theme of we need to educate people more about our degree, which is why I will start, thank you, Dr. Broadnax, by introducing myself as Dr. Nikita Patel, your nurse practitioner. But I do agree that there's this level of comfort that we as nurses have with patients that I don't necessarily think physicians do. And so I talk to them a little more like we're friends and colleagues versus this professional patient relationship. So I agree with that. That is maybe why I do that kind of innately.
And so I'll take this out. There's a question from Dr. Williams, and then we'll ask our closing question. So Dr. Williams says, I'm a nurse midwife and was initially wanted to do DNP, a doctorate in midwifery. However, I feel that I received a much more rich educational experience because I interacted and collaborated with nurses in many different fields and learned so much more due to our collaboration. Has anyone else had that experience?
Could Dr. Williams put into the chat box if, just so it can help me answer her question better, does she mean that, she said, however, she feels that she received a much more rich educational experience. Is that because she got the DNP? Is that what she's asking? And that's what I just kind of want to make sure of.
Yeah, Dr. Williams, feel free to unmute yourself and clarify.
Hi, my name is Janet Williams. I first of all want to thank you all for doing this. This has been awesome. I definitely did do the DNP instead. The program I was trying to get into with the midwifery was taking too long. And so I ended up doing the DNP, and I'm so happy that I did it. Dr. Thomas, I was also in the military, I'm sorry, I'm saying it wrong. Dr. Brodnix, I was also in the Nurse Army Corps. And when we talk about titles, I was in the reserves for 8 years, and it took quite a while until I felt comfortable being called ma'am. I was in my 20s, and it was hard to get used to that title. And I think when I first graduated with my doctorate, it was kind of hard to get used to it. But now, little by little, it's being used at work. On the floor, I'm still, we call each other by our first names on the floor, the doctors and the midwives and the nurse practitioners. However, when I present or when I'm in a formal meeting, I am addressed as doctor. So I just wanted to know, did anyone else that went into the DNP, did they feel that if they had a specialty DNP, did they feel that they got a more rich education because of it?
So I'm going to answer that question and say yes. And that's because when my program was, when I started my program, when I applied, it was in its second year. I started in its third year. And what I had noticed, and this is one of the big differences between a regular master's prepared nurse practitioner program versus the DNP at my school, it has changed since then, was that my program, family nurse practitioner track at the University of Washington required 1,500 hours of clinical practice. Contact hours. And so it was a 3-year with every summer program, one of my, I had clinical starting the first day practically, and every week, 2 times a week, including a fellowship at the VA, which added on to my clinical hours. And so with that, I got a ton of great clinical experience. And so, yes, I really do feel that I had a very rich experience, and it's helped me a lot. To be able to launch into my own independent practice here with my healthcare organization.
And I know we have another question from Bim, if you want to unmute yourself and ask your question to the panel.
Absolutely. Thank you so much. And thanks for all the questions and the discussion so far. I mean, this is wonderful and definitely much needed. I'm Bim McIntyre. I'm also one of the board members for the DOCs. So this was actually a comment that was posted on the Facebook, the YouTube live feed, and I just figured I'd ask and use this as an opportunity to get some feedback from the speakers, from others who are here present. So the comment is, I've been hearing that hospitals are making advanced practice nurses sign forms that prohibit them from using the term doctor. So my question to the panelists is, have any of you experienced this? And what's your advice for a DNP prepared nurse who the institution asks to sign a document that says they can't be referred to as doctor? I think this is actually based on a real life event.
I think that's severely, I want to say almost ignorant, because the term doctorate doesn't belong to any profession per se. And people, you can be a PhD prepared doctorate, you could have a, like you said, a PharmD, you can have a numerous different ways that you can be called doctorate. And I think people need to get that education for a hospital or a healthcare organization to put something like that in writing is appalling. Yes. And I think that I think an organization, the people that work in there should not stand for that.
Right, and I would say that I would question what they do with the other professions that have doctorates in terms of their credentialing. So you have your physical therapist, your pharmacist, your psychologist. There are a lot of people who work in a healthcare setting who aren't medical doctors who also have that title. And if I were in that institution, I would ask if this was being applied to the other professions that aren't medical doctors as well.
I will say there are some states that have it written in law, and it was due to AMA lobbying and putting forth legislation to prohibit nurses that have their doctorate to use the title. I think it was one state that comes off the top of my head. I think it was like Ohio that has it in law that you can't.
But that seems strange, because when you go to any school of nursing, all of the professors have their doctorate and they use their title.
I think sorry.
Go ahead.
I think the concern is using it in a clinical setting. Dr. McCamey, I was actually reading an outdated article from the New York Times that talked about how New York, Delaware, and Arizona had passed laws or trying to pass legislature saying that anyone beyond a physician should not be using the term doctor in a hospital setting. And it was a director from the AMA essentially saying that this would cause confusion for patients. And again, I think that goes back to the whole underline is that people are not educated. A doctorate simply implies that we are experts in a subject matter, not that we are physicians or, surgeons. And that is where the problem really is that people don't understand that.
Hi, for the hospital system that I work with, they won't allow the DNP prepared nurses to have their badge changed to reflect doctor. They tell you to, they don't change the title anymore. Once you're a nurse practitioner, you're a nurse practitioner, and they won't be welcoming changing the title on your badge. And this is Georgia.
Well, I have a whole nother career doing other things. I would say continue to advocate for yourselves, and we've spent a lot of time earning those degrees, and you should be able to speak about them as you would in any professional setting. So I want to offer the opportunity for other folks, if you have questions, to unmute yourself. We'll take maybe a couple more, and then we'll ask our closing question. So if anyone else had any additional questions tonight, if you want to unmute yourself and throw them out to our panel or in your fellow DNPs.
Dr. Parra, can I comment on what you just said?
Yes.
I think that's a great point, what you made, and I agree with you that if you have it, you should be able to put it on your badge. Specifically where I work as well, when I was attempting to, I hope I don't get in trouble for saying this, negotiate when I first accepted my job, and I made reference to the value of my degree, the response I got was that you don't need the degree that you have to do the job. You need the certificate or certification that you have to do the job. And I think that's where some of these issues are, is that technically your title, my title, we are nurse practitioners, and that is what our badge reflects, not that your badge reflects your degree. And so again, education, but I think that might, to play devil's advocate, maybe that's why they say that. So that's why I made a point to put it on my business cards, and it is on my signature and in my email, because that is my degree.
And Dr. Patel, just to piggyback on that, I mean, we work for the same hospital system, and I think that for me, I do think that because we do bring a certain level of skill and value to the institution that ultimately saves them dollars and cents and also improve patient outcomes on the back end, I feel like we do have to carve out space so that that is recognized and valued. And so some of the spaces, I know for myself, now that I'm in a leadership position, I've just created space. I mean, like, we're part of the doctoral system-wide doctoral nurses collaborative, where we have nearly 80 individuals that identify as doctorally prepared nurses that we collaborate across the system to help with doing PI and QI projects. We talk about professional development. We do all types of journal critiquing, mentoring, accountability groups, the list goes on. And then in my own particular department, I have 4 doctorally prepared advanced practice clinicians. And in my 2 years of being in the leader, we've managed to push through 2 IRB approved studies, and are actually doing things to impact clinical practice. And so I'm trying to build the stage so we show our value and can make a case to get compensated for it.
And I just wanted to add, there's also the divide within nursing itself between the PhD and the DNP. I've gone to some national conferences where people have referred to the DNP as a PhD light. They were told they couldn't teach until they had a PhD. And so even among our peers who have their PhDs, there are some people who don't view a DNP with the same value as they do a PhD.
I was gonna wait. I thought Dr. Glymph might get in there. Okay, here he is.
I think people don't understand it. I think I think that's the bigger picture. I know in academia, that's definitely because it's such a new degree. Higher echelon academics don't understand it.
Well, it's interesting to me too, because I was in a session, I guess, at the Southern Nurses Research Symposium, or one of these big conferences, and the PhD people were adamant that DNPs couldn't teach. And so one of the PhD facilitators said, what in your PhD program prepared you to teach? What's in your curriculum that certifies that you can teach anything?
Wow.
So, there was some, people got checked. I understand, they're doing research. We do research too. We publish too. But, they're still wrestling with, is there a difference between the two types of terminal degrees?
And I'm going to piggyback on you, Dr. Broadnax, because in graduate school, that's exactly what they were wrestling with hiring faculty, et cetera, et cetera. But for some reason, it was just fine for me as a graduate fellow to teach classes as a DNP student. So why can I teach classes as a DNP student, but not teach classes as faculty at the institution I'm being trained? So I do think that definitely there's that tension, but you do see that there are different universities and colleges now that are hiring DNP prepared nurses as faculty. It's starting to change.
I mean, and this is my thought. I think the teaching is there's no issue. The problem lies in is when the grants. You're talking about R01 grants which we have to change, because R01 grants, DNPs are not even eligible to be a PI on those type of grants. It has to be a PhD person prepared, and that's and to me, and that needs to change. They can get other grants, but they can't get the R01 grant, which is the big prize in academia, is those R01 grants.
There has been lots of discussion in the chat. Also, folks talking about signing patient medical records. Are there any other questions from the floor that folks wanted to ask tonight? Any other pressing questions before we move to our closing question?
Yeah, I just had one question. Hey, that's okay. Yeah. Hi, my name is Taylor. I'm a DNP psych nurse practitioner student at UF, University of Florida. So my question is just, with the DNP being kind of practice and policy and education leadership kind of degree, and our certificates being, whatever specialty we go into. So for me, it's psychiatry. Do you think that it's also a problem where the certification portion of our programs are not standardized enough for people to recognize the DNP as significant? Because what I've kind of noticed is it seems like, because if you go on any nursing forum and people have their qualms about the school that you go to. Oh, you went to this school. Oh, you must not have gotten a quality education. And so I think because there's like a lack of what seems to be standardization, people tend to look at nurse practitioners already in kind of a bad light. And then they add on what school you went to. And then they add on, oh, you have a DNP, but it's not a PhD. So kind of like, I guess the question part of that is, do you think a lack of standardization has something to do as well with kind of the lack of, I wouldn't say respect, but kind of, the way that people look at us?
I was going to say the flip to that is PhDs don't specify either. So you get, a doctorate in philosophy is what you get. And there's no specification in it in terms of what your practice area is. So it's even more generic than what a DNP is. That's just one way to look at it.
Dr. Patel, were you about to say something?
I just want to clarify, are you saying that like a doctoral program's curriculum is not standard across all programs, or what do you mean by standardization? I don't understand.
Yeah, so kind of like, so the DNP essentials are, so as far as the DNP degree itself, across any DNP you get, you have your essentials that we have to meet. But when it comes to like the base, so if I'm like, and as a nurse practitioner, the education I got from my university is not necessarily the same that someone else got from their university. And so if a physician group is trying to hire me, they have to then look at, what my education was like. And because they can sit there and say, well, so-and-so's education was not the same as your education, so I'm going to hire you because their education wasn't as good, then that kind of sullies the name of the profession as a whole. And I'm wondering if that kind of contributes to why people don't regard the DNP as valid.
But I think the same thing happens with the PhD, because you have nurse practitioners who get their PhD and they don't specify what their concentration is either. They, they have a research topic or an area that they specialize or they concentrate their research in, but they don't necessarily have to declare any particular concentration in order to get the PhD.
And I also, just to chime in, I also think, because this has been in conversation with AACN, with them examining, because there's been such a huge boom in DNPs in schools offering DNP programs, that there's been question about the rigor of curriculum. And so, you know, there's been like a pop-up of for-profit online. So there's this huge controversy with the quality of education that's being provided to students. And I know AACN was in the process of writing a white paper and creating a task force to look at these different institutions to examine their curriculum, their faculty, their accreditation. And so I do know at the institution that I work for, we have X amount of institutions that we won't hire anyone from just based off either they were like for-profit institutions or they have a historical kind of reputation of not having rigorous accredited institutions of education. So yes, I do think that when you are looking for programs, that looking at their track record, their accreditation, the diversity of faculty, the faculty's credentials, do they have specializations that you're interested in so that you can have a mentor for your DNP project? So those are some of the controversies that are coming out because of just the huge boom in DNP programs just basically popping up in the past 7 to 10 years.
I mean, and I want to piggyback off that because, yeah, you know, and for my DNAP, it's specialized in safety because that's what VCU and the anesthesia program specializes in. But you're right, with a PhD, you still have to have somebody, your advisor, that is familiar with your topic of interest, so you can help, so they can help mentor you to that process. So it is either with a DNP or a PhD, you need that mentorship. And like I said, it all boils down to education and understanding of both aspects.
Right. Yep. I'd like to chime in with that student. My name is Kendra Thompson. I'm a recent graduate of the University of Tennessee Health Science Center. I think that that's something I found. I just finished their dual family and psychiatric nurse practitioner program. And some of the people that I was trying to mentor with in the psychiatric nurse practitioner groups that I kind of found were very adamant that in order to get into a psychiatric nurse practitioner program, that you needed to have experience as a psychiatric nurse first. That you couldn't be a good psychiatric nurse practitioner if you had no mental health background. Then also there's did you go to a brick and mortar school? Did you go to an online school? If you did go to an online school, what school did you go to? So I think that when we look at all of these things, I think we have to kind of verify and kind of maybe have more of a standard when it comes to nursing education, because there are universities that are for profit and all they care about is money, and they're like diploma mills and they'll let anybody get through. And there's no standard, there's no rigor, there's no accountability that the students are held to. And I think that is something that we as nurses have to advocate for, that we have to have some sort of standard education. We have to decide what makes a DNP as far as education goes, because we do have these physician groups that are lobbying against us. And in order for us to stand tall as in our profession, we have to say that, yes, this is what it takes to become a nurse practitioner. And when you look at how many hours, some DNP programs only have 1,000 hours. Some DNP programs have 1,500 hours of clinical. So when you look at that and you've got these doctors that are coming out and saying, you know, these nurse practitioners only have 700 hours. That's no way. They should never say that. They should not be able to practice independently.
I just want to piggyback on Dr. Thompson. By the way, she was my mentee. Woo woo! Congratulations to Dr.
Thank you, babe.
Thompson. I just want to piggyback on her because I know that we do a lot of criticizing of our profession, and we should be critical because we want to improve, we want to move forward. But as a medical director, I have had to interview, I don't know how many physicians for different roles to work in my clinic over these last couple of years. And I'm going to tell you that there are some people, when they come to the table and we're all sitting at the table and we're asking them clinical, like, did you learn this? There are physicians that got out of school that don't know how to suture. So I'm just saying, okay, it's the same on both sides. So the bottom line is we have to be proud of who we are. We have to self-criticize so we can grow. But and we are making strides with the DNP essentials. They're there. They were loose in the beginning, but they're getting better, as we all know. And but I want you all to know that process of me having to like dig in on the physician side, thinking that people are coming completely able to. I've had people sit at my table say, "I do not do kids and won't do it." But you're in family practice. I mean, you know, they're like, well, no kids, 12 and up, 18 and up, internal medicine saying, I don't do annual wellness visits, but you're an internist. So because I don't feel comfortable. Okay. So I'm just saying that it's really about our experiences and what we bring to the table. We can't expect that we're all going to come out perfectly ready to do whatever our specialty is. But there's gaps everywhere. There's gaps in medical education as well. So you yourself have to seek out what you need to know to be comfortable in the setting that you want to work in. I can be on that soapbox all day.
Thank you. I want to get some other voices in here from folks who have questions. Dwayne, do you want to unmute yourself and ask your question?
Hold on for a second. Hold on. I'm gonna get into the space so you can see me. Okay. Okay. Can you guys see me?
Yeah, we got you. Go ahead.
Okay. So I just wanted to ask. I'm not saying I'm necessary for this. I've been hearing some people have been pushing for the DNP role to be more clinical, which what I mean by that is more like if somebody wants to specialize in cardiology, they want to utilize the DNP education to become more clinical, where they kind of transition into specialties or like ICU, critical care, cardiology, and nephrology. So I was trying to see how people feel about that approach, because I've been hearing it from a few people from different Facebook groups from that standpoint.
Yeah, and from the academic standpoint, I can tell you that what you're kind of referring to is fellowships,
Yeah.
Fellowships where people can specialize, especially postmasters people, so they can, many people that have already had their masters, they're kind of hindrance. They're like, well, I would love to go back if I could learn something else, if I could learn in terms of another track. So those fellowships are something that I think definitely are something to earmark to get masters prepared people to get back and go in to get their DNP. So yeah, absolutely. That's something that is definitely on the horizon.
But I think people want to change the DNP, but some people I speak to don't think the DNP is worth it unless they were, the saying, I don't get more money, I'm not going to be respected, I'm just going to have a doctorate. But some people don't really understand the true essence of doctorate. But I know some people will say if I got something like a fellowship and they call it a doctorate, whatever, in cardiology or something, they would do it, but not in the current levels that we're used to. So I was trying to think of everyone's thoughts of people requesting that it be changed to actually a fellowship, because a DNP, only way to get your doctorate is if it's actually equivalent to something like a fellowship, not the current standard that we're used to through the essentials.
I mean, I don't think the essentials need to be changed. I think the curriculum is appropriate. What you're, I guess the next level, the next question is, that is that the next step for DMPs to actually have fellowships also, that and the DMP is, I think that body of knowledge is sufficient for advanced practice nurses, but I think what people are also looking at is other fellowships so they can become more expertise in that particular clinical field.
Mm-hmm. Yeah.
Dr. Patel, were you trying to chime in there?
Yeah, I'm actually like kind of torn how I feel about this. I don't think I'm pro that. I am a family nurse practitioner because it lets me do a lot. And, right now I work in vascular and I love it. And it touches on a lot of chronic disease management, but there's a lot of overlap with cardiology, with nephrology, with wound care, with endocrinology. And so like, I personally enjoy having the freedom knowing that should I decide that I've learned what I wanted to learn in vascular and I want to expand my scope and I can go to cardiology next, I enjoy that. Will it be a learning curve and is it a lot that I have to self-teach? Yes, absolutely. I don't know. I think it would get incredibly confusing. It was all residency type, like what you said, like everyone has a specialty that's designated to them. And then that you're kind of siphoned into that. I don't think it's a bad idea in regards to, will people maybe respect the DMP more or advanced providers more? But as someone that's as practicing as an FNP, I like the freedom of being able to move about specialties or just work in internal medicine or family medicine and kind of touch base on everything. That's just my own personal opinion.
Do other panelists have anything on that?
I just think it's something that's interesting about, it depends on the program that you go to, but this is another thing where I was saying that standardization piece might be a little bit more helpful, because in my program, we have like residency hours that are part of the DNP.
Mm-hmm.
And so on top of us working on our project and kind of, working in that realm, we also kind of get to focus on what we want to do. So for me, for example, I want to do LGBT and Black Indigenous people of color, their mental health and their wellness. That's my primary focus. So my residency hours are going to be focused on, doing continuing education modules and continuing education trainings on specifically doing affirmative therapy and working with trans youth and working with Black youth and like what that means for me as a clinician. But I know that not in every program do you get that chance to kind of focus your education. And I think that's kind of what, not to misspeak for what he's saying, but kind of what I interpreted what Dwayne was saying is having that chance to kind of focus in on especially what you think is interesting and what you're trying to practice.
Mm-hmm.
But at the end of the day, like if in Dr. Patel's case, like I will be a psychiatric nurse practitioner across the lifespan. If I wanted to go into child and adolescent psych after working with, teens for a certain amount of time, that's something that I could do. So I think that it's just like being able to focus while you're in school on kind of your interests might be helpful to develop the degree.
I agree. I don't know how all programs are set up. Where I went to school in Florida is similar to your program, Taylor, that there are designated residency hours or elective hours, I guess you could look at it, so that you are able to pick if you want to be if you want to do family or if you want to try to explore specialties to determine what you want to do. And then, I even use that experience when I went to look for jobs that I wanted to work in a surgical specialty. And I had done many hours in that, knowing I had interest in it. And so that was kind of my, I guess, equivalent of a residency, that I have so many clinical hours in surgical specialty experience.
And I ditto that. I did my focus, a lot of focus on HIV. I did my regular family nurse practitioner required hours and a lot of hours in HIV and STIs.
I did my DNP project in cardiovascular, developing a program to improve in-home care after patients get out of the hospital. But regarding a residency, I would like to see something more structured, similar to what the residents get in med school. Many years before I became an NP, I was a critical care nurse. So we essentially taught the residents when they came out their first years. And you can see the benefit of doing rounds during their lunch breaks. They get lectures. And I think maybe at least 1 year of our DNP programs, if we took that didactic approach and maybe even did, 4 weeks where we're doing intensities on each particular body system, each particular specialty, that would bring a more prestige to the DNP degree. I felt like my degree was more quality based, and the medical benefit that I got out of it was what I put into it. It was not what was structured into the curriculum. So I can understand where individuals want to see more of a residency requirement, and I think it would benefit overall. I do see particular hospitals after we graduate that may offer a residency for 1 year, but I don't necessarily think that the way that DNP programs are set up, that they will improve you clinically. They're going to improve you more on a quality spectrum.
Dr. Johnson, you gave a really good insight into some of the complexities of being able to be clinically prepared as we come out. And I just want to bring highlight, because some of you doctors on that are participating today might want to do something like this in your facilities. But one of the programs in my program, in the F&P track, they got a grant with the local VA of Seattle, and they did a grant to provide 2 fellowships to 1 year fellowship / not 1 year, 1 to 3 year fellowship residencies for F&P students. And so we basically walked alongside the residents in the VA who were there, and we were there a few times, like 1 to 2 times a week throughout our DNP program. And we got exactly what Dr. Johnson brought to the table, is where we got to focus on, cardiology, how to manage heart disease, how to manage diabetes. I mean, it was lectures. We got to collaborate on different things and have clinical. So that was extremely valuable. And I do think that, and it's not unattainable for it to be replicated, but it was grant funded.
I think it would take, maybe even expanding upon our DNP essentials. I know that they're very, complex and they're very comprehensive, but I think with regard to, we fight a daily battle with the AMA. They're always trying to deduct from our benefit. They're scared, I believe, that we're going to take their patients. We're more comprehensive than what they are because we know bedside and we know management. So I just personally think that in the long run, I'm in one of the last states to get independent practice. I'm in Florida. We're fighting that battle right now. We're almost there. We're setting up our rules. But I think in order to maintain or really get that prestige and that respect, that we should consider rearranging our programs to include on the doctoral level at least 1 year of clinical.
Thank you, Dr. Johnson. Are there any other questions from the floor, folks who have burning things you want to ask this evening? You do, just go ahead and unmute your microphone and jump in.
I just want to touch base on what Dr. Johnson said. So I think she made a good point of expanding it for a year. The DNP, that's what I was really talking about, expanding and changing it, whereas the fellowship is actual part of the doctorate program. So that's what people are pushing for. I was on the committee. I was actually one of the founders of one of the first fellowships in Columbia, South Carolina. We actually worked with the hospital and actually had a plan set. And like Dr. Johnson laid out, we had lectures, we had multiple specialties. They all agreed to be on board to train nurse practitioners through all the specialties once a month. Right? And we even had a launch date. Right at the launch date, the hospital pulled the plug on us and we just had to cancel everything. So everything just went by a wayside. So it was very disappointing, but we were about to form one of the first fellowships in South Carolina. The closest fellowship we have is in North Carolina. So I was actually part of the preceptor team and kind of actually set up a preceptor actually vet all the preceptors and actually have them readily available, because, you know, preceptors are hard to get. So we actually had a team of preceptors that are readily available no matter what. But unfortunately, that fell by the wayside. So hopefully since I have my doctorate, I'll probably use my knowledge to hopefully pursue that again. But I think that's a great idea to expand it as part of the doctorate. I think I never thought of it that way, but I think I like how Dr. Johnson laid it out.
Awesome. Well, thank you all so much. This has been a really interesting, robust conversation, and I think a lot of education for me personally, and I think for each other about how I think how you refer to yourself with your patients. And as a person who just got out of the hospital recently, I would have happily heard I'm your doctor. So we have one final question for our panelists tonight. Just sort of to wrap up, we want to go around and hear from each of you. What parting advice do you have for those who are pursuing or are already in practice as DNPs? So yeah, what's your advice to your colleagues? We can start in the reverse of how we began. We can start with, why don't we start with Dr. Thomas?
Pearls of wisdom.
Well, clearly, those of you who are on this webinar and those who are streaming live, you're interested, you're eager, you're curious. So I don't have to say to you, be curious, but I can say, use your curiosity, use your passion, use your excitement, use the skills that you have learned in your programs, in your DNP education, to make a difference. Even if it's minute, you don't have to change the world, but you can change your community, you can change your clinical environment to improve the care for the people that we love in our communities that look like us. And so if I had any parting advice, that probably would be it.
Thank you. Dr. Brodnax.
Sure, I would like to say that the DNP, as I mentioned before, it's not a position, it's where you are in your practice. And once you get your DNP, you become a strange animal, because when you look at positions, there are more master prepared positions out there than there are doctoral positions out there for folks with our skill set. And especially if you specialize, my focus is in quality and safety. But if you want to expand your practice to incorporate the scope as a DNP, I think you're going to find that there are very few jobs that are created for us. But the exciting thing is you have this skill set now, so that you can look at where the puck is going instead of where the puck has been. So it actually helps to position yourself to broaden your horizon and to look at other positions that traditionally weren't open or available to nurses. So go for it.
Thank you. Dr. Patel.
Wish I had something as inspiring as Dr. Thomas and Dr. Broadnax. I think just know what you want to do and be motivated and help us advance this profession, or this degree rather, and bring light to what we do and how great it is. And I think some people, as with any degree, they just go because they want to advance or they think it'll be more money. But I really hope that everyone that is pursuing their DNP is doing it for a reason and can really make efficient change, because it's a really powerful thing that we can do. And I just don't think people know it yet. And so I really hope that we continue to spread the word on what doctorally prepared nurses are capable of.
Thank you. Dr. Glymph?
Wise man once said, you can't lead where you don't go, and you can't teach what you don't know. And I think DNPs are leaders. They are leaders in our profession. The reason why I pursued the DNP when its first infant stage is because just that I wanted a more body of knowledge. So I think those that are pursuing that and those that have attained it, they're leaders in their field in terms of whether it be in quality improvement, whether it be in legislation, whatever field they're in, they become the leaders and they become the voice for those that are practicing evidence-based. So I think that's the parting that I would like to leave.
And Dr. McCamey, I'll turn things back over to you.
All right, thank you so much, everyone, for your engagement and really sharing your stories, your experiences. I know it's been proven valuable to everyone that was on our program for tonight. Cianti, if you want to go to the next slide, we'll just go ahead and close out. So just want to say thank you. And then also, please like, share, follow, subscribe. We're on all the major social media networks. You can send us an email, check us out on the web. For those that are interested in seeing how you can get connected with DNPs of color, volunteering, opportunities for speaking, writing, research. I'm gonna give a plug out to Dr. Akintade. He is the chair of our research committee. So if you're interested in doing some research, and so just feel free to reach out to us. And we thank you again for sharing of yourself, your time and your energy. And we wish you well. Thank you, everyone.
Thanks, everyone. It was
Thank you so much.
guys.
Amazing. Woo-hoo.
Join us, join us, join us.
We will.
Thank you so much, everyone.
So much.
Good night.
Have a good night.
Thank you. Thank you. Good night, everyone.